Welcome everyone. Today's topic is osteoporosis. I'm ChicagoDLSinc. I do group sessions and one-on-one tutoring for the Naplex and the MPJE. If you have taken the Naplex before and have a score report, you send me a DM. I'm happy to review that for you. If you have taken an assessment and want to discuss the results of that, also send me a DM. Happy to review that as well. If you're new, save your questions. I will happy to answer all of them at the end. My resources are RxPrep and Pass Naplex Now. These are mini lessons. They're not meant to be comprehensive. While we're doing these, if you feel like there's a topic or a concept you're unaware of, make a note to go back and review that. Always best to do that after the sessions or the next day to make sure that you're able to retain the material. Shout outs to Suspicious Bunch and Pharma Turtles for arranging all of this. These are not comprehensive reviews. When I do them again in the future, I do tend to add material, and then we'll do some practice questions at the end. And don't forget to fill out the survey so we can use your feedback to improve. All right. So the background, osteoporosis is loss of bone density, and there's some prevention or lifestyle measures to reduce bone loss. One is diet, consuming adequate calcium and vitamin D. Recommendation is 1,000 mg per day for men, 50 to 70 years of age, or 1,200 milligrams per day for women greater than 51 years of age, and for men greater than 71 years of age. Vitamin D, about 800 units per day, and then milk in 8 ounces, you get 300 milligrams of calcium. Celiac disease is a contributor to osteopenia, and so if you have a patient that has celiacs, make sure that this is being monitored and they're on a gluten-free diet. Weight-bearing exercises help bone density and then reduce the risk factors for osteoporosis, which are smoking, coffee, alcohol use, or glucocorticoids. Now, for you coffee lovers out there, I also enjoy good coffee from time to time, almost every day. Too much coffee is a bad thing, but as is too much water, you can drown yourself. So everything in moderation. Next, we have guidelines for identifying patients at risk for fracture. So, bone density testing for all women age 65 and older and men 70 and older, unless, of course, they have risk factors such as family history, then we change the screening to earlier, such as 50 years of age or older. In addition to family history of osteoporosis, smoking, excessive alcohol intake, if they're underweight, or they take long-term steroids, and then postmenopausal women that are 50 years of age or older. Bone mineral density estimates the true mass of bone. The DEXA scan is a quick, painless, and the preferred method to measure bone mineral density. If you're unfamiliar, the DEXA scan is x-rays of the entire, they do a skeletal survey, and they're able to check the bone mineral density. It is more accurate than x-ray or CT scans, and so to clarify, it uses radiation technology, but it does use less radiation. Increases in bone mass can be seen in as little as 3 months after starting medication therapy. And we use a grading called the T-score. And so, for example, you have a patient, today's day 1, you do the DEXA scan, and then you start them on medications. 3 months to 6 months, you repeat it, and you can see an improvement in the T-score. So greater than or equal to 1 is normal. Negative 1 is normal. Between -1 and -2.5 is low bone mass. This is classified as osteopenia. and below negative 2.5 is defined as osteoporosis. So there's a nice list of medications that may cause osteoporosis. Corticosteroids are number one. There are several anti-epileptics like phenobarbital, phenytoin, primidone, valproate, and carbamazepine that can cause osteoporosis. Anyone in the chat, can you tell me a brand name for carbamazepine? Once again, in the chat, a brand name for carbamazepine. Next, we have aromatase inhibitors, arimidex, femora, and aromacin. We also have gonadotropin releasing hormone agents, then proton pump inhibitors, PPIs, TZDs that we use for the treatment of diabetes, in addition, SGLT2 inhibitors. For those of you that answer Tegretol, that is correct. Great job. Next, we have SSRIs, Depo-Provera, heparin, lithium, and then methotrexate as well. So let's talk about some treatment options. The first one is going to be SERMs, selective estrogen receptor modulators. Raloxifene, brand name Evista. The dosage is 60 milligrams once a day. The mechanism of action, it has estrogen-like effects. They're tissue specific. It inhibits bone resorption, decreases bone turnover, and usually chosen for osteoporosis when there's also a need for breast cancer prophylaxis. The side effects are going to be hot flashes. It will not alleviate menopausal hot flashes and may cause it in previously asymptomatic patients, so you have to be careful about that. It can also cause leg cramps, VTEs, and the greatest risk is in the beginning of treatment. Anytime there's prolonged immobilization, you want to discontinue 72 hours prior to and then during the prolonged immobilization. Another adverse effect is hypertriglyceridemia, which you want to be careful of. Now, a couple drug interactions that are important. One is cholestyramine, and that can cause a decreased absorption of Evista. And levothyroxine, Evista may decrease absorption of that. So you may need to increase the levothyroxine dose or choose another bisphosphonate. SERM. Patient counseling, we want to take with or without food. If there are any DVT or PE symptoms, change in vision, abnormal vaginal bleeding, or breast pain, do not use if there's a history of blood clots or the patient is pregnant, and avoid taking concurrent estrogen therapy. Now remember, because raloxifene is a estrogen receptor modulator, if the patient is also taking estrogen, you're activating the receptors double. So do not co-administer with cholestyramine, which we talked about the decreased absorption, and it's not recommended in premenopausal women. And if the patient is going on a long trip, recommend below the knee compression stockings. Also, this is general advice, and when you're on long flights or long train rides or long car rides, you should plantar flex and relax your feet to keep the blood flow going in your lower limbs and make sure you hydrate. So let's talk about bisphosphonates. The mechanism of action is here. They inhibit osteoclast-mediated bone resorption, and bisphosphonates stay in the bones for years after stopping. So in mild osteoporosis, we recommend stopping treatment after 3 years if it's IV therapy and 5 years if it's oral therapy. Side effects are broken down by the system. GI, you can have nausea, vomiting, diarrhea, and abdominal pain. In the esophagus, you can have GERD and ulcers, along with musculoskeletal pain, headache, hypocalcemia, And then something called osteonecrosis of the jaw. There's an acronym, BONJ, bisphosphonate induced osteonecrosis of the jaw, and that can be prevented with 0.12% chlorhexidine rinse. It might increase the risk of esophageal cancer. So most bisphosphonates are very, very big pills, and we'll talk about some of the mitigation measures that we take. Also, a possible increased risk of thigh bone fractures. So, caution with hypocalcemia, inability to stand and sit upright, and chronic kidney disease. So, the brands and their dosage and their forms are listed. We have alendronate, which is Fosamax or Binosto, available in tabs and solution. Risedronate is Actonel, it's available in tabs. And then the delayed release brand is Atelvia, and this is 35 mgs taken once a week after breakfast. Ibandronate is Boniva, the tabs and IV dosage forms. Zoledronic acid is reclassed. It's IV 5 milligrams once a year. And then Zometa is a different brand name. It's IV 4 milligrams every 3 to 4 weeks. Pamidronate, brand name is Heredia, and that's available IV. You may also have heard of zoledronate, which is the same thing as zoledronic acid. So, take first thing in the morning. Do not eat for at least 30 to 60 minutes and stay upright. Swallow the tablet with at least 8 ounces of plain water. Take supplemental calcium and vitamin D. Weight-bearing exercises are important. No smoking and decrease alcohol intake. If the patient experiences difficulty swallowing or chest pain, contact their prescriber. And another very important patient counseling point is going to be if an extraction or bone surgery is necessary, recommend Paradex for prevention of osteonecrosis of the jaw. The instructions are use half a fluid ounce, 1 capful. It's also 15 milliliters, undiluted twice a day. Swish for 30 seconds. Avoid food 2 to 3 hours after, and it can cause staining of the teeth. Don't forget you store it at room temperature. Now, in postmenopausal women, oral bisphosphonates will slow bone breakdown in our first line therapy unless the patient has chronic kidney disease. The guidelines are creatinine clearance less than 30 with risedronate and ibandronate, or creatinine clearance less than 35, you can do alendronate and zoledronate. Patients with esophageal disorders or an inability to stay upright for at least 30 to 60 minutes. If they can't take oral bisphosphonates, we have zoledronic acid, IV, ibandronate, or denosumab sub-Q. If there's renal impairment, also recommend denosumab. Now, teriparatide and abaloparatide, brand name Tymlos, build bone, and they're used for severe osteoporosis. There is a limitation on that treatment for 2 years. If the patient needs breast cancer prophylaxis, we'll use raloxifene, and there is an increase in thromboembolic events and hot flashes. So for men, oral bisphosphonates are first-line therapy, alendronate or risedronate as the initial drug of choice, and then men with esophageal disorders they also have an inability to stay upright for 30 to 60 minutes. They can also be treated IV. Teriparatide, brand name Forteo, for men at very high risk of fracture or those that can't take a bisphosphonate. The brand name is Prolia for denosumab, and for men at high risk of fractures due to androgen deprivation therapy for prostate cancer. Calcitonin is less effective, so the use is discouraged. And if a patient has low T, recommend testosterone replacement. Now, we want to ensure adequate calcium and increase vitamin D intake, consume a balanced diet, regularly perform weight bearing and balance exercises, avoid tobacco, limit alcohol consumption, and take measures to prevent falls. If a patient has osteoporosis but mild, we can do a drug holiday after 5 years on oral bisphosphonates or 3 years on IV medications. Let's talk about a couple of the newer agents. Abaloperitide or Tymlos. It is a sub-Q injection, and you can use this therapy for up to 2 years. The mechanism of action, it's a parathyroid hormone analog, and its indication is treatment of postmenopausal women who have been diagnosed with osteoporosis and are at a high risk of fracture. The dose is going to be 80 micrograms sub-Q once daily in the peri-umbilical region of the abdomen and hold for 10 seconds. Before first use, it should be refrigerated, and then it can be room temp after first use. Make sure you counsel the patient to discard after 30 days. There is a boxed warning, osteosarcoma, which is a highly aggressive bone cancer, and the side effects are going to be increased uric acid, orthostatic hypotension, hypercalciuria, meaning the urinary calcium will be high, and urolithiasis, which are stones. Also increased calcium. Next, we have romosozumab. Brand name is Evenity. I think romosozumab would be an excellent Wi-Fi password. However, if you choose to do that, I will stick to data. So mechanism of action is a sclerostin inhibitor. There's increase in bone growth and decrease in bone breakdown. The indication is once again treatment of osteoporosis in postmenopausal women at high risk for fractures. The dose, it's done in the office, 210 mgs sub-Q once monthly for 12 doses. There are 2 separate injections for the total dose. Now, there is an increased cardiovascular risk for major cardiac events, low calcium levels, osteonecrosis of the jaw similar to bisphosphonates, and atypical femoral fracture. Adverse reactions, 5% or greater will experience arthralgia and headaches. Okay, so now we come to 4 practice questions. I will read the question, and then in the chat, if you can put your answer choice when I'm done reading them, and then we will discuss. So first we have, which of the following medications can increase the risk for osteoporosis? Choice A, Zofran. Choice B, prednisone. Choice C, tramadol. And choice D, methotrexate. Now, in your answer choice, if you can put the generic for choice A, I would be most grateful. Once again, along with your answer choice, please put the generic for choice A. Give everyone a chance to answer. All right. So the correct answer is B. Long-term use of steroids is known to increase the risk for developing osteoporosis. For those of you that answered ondansetron, that is correct. Good job. Remember, knowing your brands and generics is important. In the resource section or the guide that's posted online, there's a link for top 200 and top 300 brands and generics. I always counsel the students I work with, 300 is a good number. You want to be prepared. You don't have to do it all in one day. 300 terms is a lot. If you break it down into 10, 15, 20 a day, however many you can handle, you'll be able to get through them in no time at all. All right, great job, those of you that chose B and those of you that knew the brand name. Now, practice question 2. In the patients who are prescribed Dilantin long term, this can contribute to which deficiency? Choice A, folate, choice B, B12, choice C, vitamin C, and choice D, vitamin D. Also, if you would be so kind with your answer to put the generic for Dilantin in your answer. Once again, make your choice A, B, C, or D, and please put in the generic for Dilantin. Give everyone a chance to answer. All right, very good. So the correct answer is D as in dog, or vitamin D, and the generic is going to be phenytoin. Phenytoin induces hepatic metabolizing enzymes, and this can enhance the metabolism of vitamin D, therefore decreasing vitamin D levels. So chronic use of phenytoin has been associated with osteopenia, osteoporosis, and bone fractures. So good job if you chose D, and good job if you knew it was phenytoin. Know that if you're unsure of any of the answers, make sure you make a note and go back and review. Now is the time. Here is a place to get it wrong and then go back and review. So when you take the Naplex, you get it right. Now, question 3. This is going to be a ranking question. So rank the following agents in order of most frequent dosing to least frequent dosing when treating osteoporosis. So once again, when you rank, you'll use all the choices, and I'm looking for most frequent dosing to least frequent dosing. Giving everyone a chance to respond. If you're going to guess, that's okay. Put a question mark by your answer choices or just guess. There's no Penalty for getting it wrong. So we have 5 practice questions today. All right, very good. So the correct answer is A, B, C, and D. So Evista, which is the generic, the generic is raloxifene, is dosed once daily. Next, Boniva is a bisphosphonate, and that's dosed once monthly orally or IV every 3 months. So Prolia is going to be denosumab, and that's going to be dosed every 6 months, 60 milligrams sub-Q. Finally, choice D is reclassed, which is zoledronic acid or zoledronate, and it's dosed once yearly for the treatment of osteoporosis and every 2 years for prevention. Now, there are a couple other indications for zoledronic acid, such as multiple myeloma and hypercalcemia of malignancy. That brand name is going to be Zometa. So, good job if you did A, B, C, and D. And if you are unsure, go back and take a look at the dosing. Bisphosphonates and osteoporosis can also be high yield. You don't have to know all of it from top to bottom, but you definitely need to know certain certain topics like bisphosphonates. All right, very good. Let's move on to practice question 4. Mrs. GM is an 83-year-old female patient measuring 5 feet 5 inches and weighing 140 pounds. She is presenting to your community pharmacy today with a new prescription for Fosamax, 70 mg PO, once weekly. Other current medications include omeprazole, 40 mg PO daily for GERD, Tylenol arthritis pain, 650 mg PO as needed every 8 hours, calcium 1200 mg daily, and ergocalciferol 50,000 IU orally once weekly. Most recent labs are sodium 135, potassium 3.7, and serum creatinine of 0.9. She states that the doctor told her this new medication was because of her moderate risk for developing a fracture, but did not give any more information. Which statements are true about Fosamax? Select all that apply. So, select all that apply. One of them could be correct, all of them could be correct, or anything in between. Both RxPrep and past Naplex now do a great job of not having a pattern. Remember, there's no pattern on the Naplex when it comes to select all that apply. So choice A, Fosamax works by stimulating osteoblastic activity, which promotes bone formation. Choice B, she should take this medication first thing in the morning and wait at least 30 minutes before eating and remain upright for at least 30 minutes. Choice C, if oral formulation is not tolerated, there is an IV formulation of Fosamax available for administration. Choice D, she should take this medication with a full glass, 6 to 8 ounces of water. Choice E, use of Fosamax should not be administered to our patient due to renal insufficiency. All right, getting some answers. Another minute for everyone to get a chance to respond. Very good. So the correct answers are going to be B, as in bisphosphonate, and D, as in vitamin D. Let's talk about why. So, choice A is incorrect because bisphosphonates inhibit osteoclast activity, and here it says it stimulates osteoblasts. That's why choice A is incorrect. Choice B is correct because these are the steps we take to reduce esophageal irritation and to increase the absorption of Fosamax. Choice C is incorrect. Fosamax is only available orally. There are other bisphosphonates that are available IV. Choice D is also correct because only 6 to 8 ounces of plain water should be taken with alendronate. Other beverages can increase esophageal irritation and reduce absorption. Now, choice E is incorrect because alendronate is only contraindicated in creatinine clearance less than 35. If you were going to calculate this patient's creatinine clearance, you would be 43. You would be at 43 milliliters. So, good job if you chose B and D. Now, this question would fall under area 2 of the Naplex, and that's going to be identifying drug characteristics. So, Charmut has a good question. Would the Naplex try to trick us with E being an option, let's say, for a different med? Are you saying maybe they put another bisphosphonate or a different osteoporosis option? I would say yes. Remember, it's not a trick. It's supposed to gauge your baseline knowledge. And so, you know, the pharmacists that are going into retail are going to complain about the hospital meds. The hospital pharmacists are going to complain about the retail, maybe meds or instructions. And then the nuclear pharmacists are going to complain about both. So it shouldn't be a trick. It should be the baseline knowledge that you're expected to know. Good question. But yes, they may put a different one that does fall into the guidelines of the patient having renal insufficiency. All right. All right. So the correct answers here are going to be A as in apple, C as in cat, and F as in Frank. So before we talk about A, C, and F, know that patients that take amitriptyline or other TCAs, they are known to be at an increased risk of falls. So even though the patient is only 55 with a history of hip fractures, probably a good idea to take them off of that and switch them to maybe Wellbutrin or something else. Now let's talk about these answer choices. This patient is very high risk and also has prior fractures. So we would want to do um, any one of the drug options that are appropriate for high-risk patients. However, with a creatinine clearance of 23, we would have to rule out bisphosphonates, which would be reclassed and Evenity. So choice D and E. All right. So Evenity also has, sorry, B and D. Evenity also has a black box warning for an increase in MI, stroke, and cardiovascular death. And so, because this patient has had an MI 6 months ago, Evenity is going to be contraindicated. So here we now have Forteo, Tymlos, and Prolia. Those would be the appropriate choice for this patient. All right, very good. Questions or concerns about this topic? Questions or concerns about the practice that we did in general about the MPJE or the Naplex?